Okay, so we're going to start with coronary artery disease and acute coronary syndrome. Coronary artery disease, or CAD, is the most common type of cardiovascular disease and accounts for the majority of these deaths. Patients with CAD can be asymptomatic or may develop chronic stable angina or chest pain, unstable angina, and myocardial infarction, or MI. Those are more serious manifestations of CAD and are termed acute coronary syndrome, or ACS. The American Heart Association estimates that 1.1 million Americans will have an MI each year, and about 1/4 of these will die in the emergency department or before reaching a hospital. Although the mortality rate for MI has decreased due to advances in treatment, it remains the leading cause of death from all cardiovascular diseases and death in general. So there's different stages of atherosclerosis. In figure A, the endothelium, which is the inner lining of the vessel wall, is normally non-reactive to platelets and leukocytes, as well as coagulation, fibrinolytic, and complement factors. However, the endothelial lining can be injured as a result of tobacco use, hyperlipidemia, hypertension, toxins, diabetes, and infection, causing a local inflammatory response. CAD is a progressive disease that develops over many years. When it becomes symptomatic, the disease process is usually well advanced. The stages of development in atherosclerosis are 1. Fatty streak, 2. Fibrous plaque, and 3. Complicated lesion. So figure B shows the fatty streak. Fatty streaks are the earliest lesions in the process, and they're characterized by lipid-filled smooth muscle cells. As streaks of fat develop within the smooth muscle cells, a yellow tinge appears. Fatty streaks can be seen in the coronary arteries by age 15 and involve an increasing amount of surface area as one ages. Figure C is an example of fibrous plaque. The fibrous plaque stage is the beginning of progressive changes in the endothelium of the arterial wall. These changes can appear in the coronary arteries by age 30 and increase with age. Once endothelial injury has taken place, lipoproteins, which are carrier proteins within the bloodstream, transport cholesterol and other lipids into the arterial intima. Collagen covers the fatty streak and then forms a fibrous plaque with a grayish or whitish appearance. These plaques can form on one portion of the artery or in a circular fashion involving the entire lumen. The result is a narrowing of the vessel lumen and a reduction in blood flow to the distal tissues. In fact, in figure D, this is a complicated lesion. This is the final stage in the development of the lesion and is the most dangerous. As the fibrous plaque grows, continued inflammation can result in plaque instability, ulceration, and rupture. Once the integrity of the artery's inner wall is compromised, platelets accumulate in large numbers, leading to a thrombus. The thrombus may adhere to the wall of the artery, leading to further narrowing or total occlusion of the artery. At this stage, the plaque is referred to as a complicated lesion. On this slide, we have an example of vessel occlusion with collateral circulation. So figure A is just an open, functioning coronary artery. Figure B is a partial coronary artery closure with collateral circulation being established. In figure C is total coronary artery occlusion with collateral circulation bypassing the occlusion to supply blood to the myocardium. Some risk factors for CAD include non-modifiable risk factors, which are age, gender, ethnicity, family history, and genetic predisposition. So risk factors are characterized or conditions that are associated with high incidence of the disease. Many risk factors have been associated with CAD. The incidence of CAD and MI is highest among white, middle-aged men. After age 65, the incidence in men and women equalizes, although cardiovascular disease causes more deaths in women than men. On average, women with CAD are older than men who have CAD, are more likely to have comorbidities like hypertension or diabetes. Most women have atypical symptoms of angina rather than MI when presenting with their initial cardiac event. African Americans have an earlier onset and more severe CAD than their CAD counterparts. Additionally, CAD incidence and mortality rates are greater in African American women than their white counterparts. Family history is a risk factor for CAD and MI. Most times, patients with angina or MI can name a parent or sibling who has died of CAD. The genetic basis of CAD and MI is complex and poorly understood. It is estimated that the genetic contribution to both CAD and MI is as high as 40 to 60%. This proportion relates mainly to genes that control known risk factors. Something, for example, like lipid metabolism. Modifiable risk factors include elevated serum lipids, elevated blood pressure, tobacco use, physical inactivity, obesity, diabetes, metabolic syndrome, and elevated homocysteine level. Elevated serum lipids. An elevated serum lipid level is one of the four most firmly established risk factors for CAD. The risk of CAD is associated with serum cholesterol level of more than 200 or a fasting triglyceride level of more than 150. For lipids to be used and transported by the body, they must become soluble in the blood by combining with proteins. Lipids combine with proteins to form lipoproteins. Lipoproteins are vehicles for fat mobilization and transport and vary in composition. They are classified as high density, so your HDLs, and then you have LDLs, and then you have VLDLs. So you have high density lipoproteins, low density lipoproteins, and very low density lipoproteins. HDLs carry lipids away from the arteries and to the liver for metabolism. Therefore, high serum HDL levels are desirable and lower the risk of CAD. In general, HDL levels are higher in women, decrease with age, and are low in persons with CAD. Physical activity, moderate alcohol consumption, and estrogen administration increase HDL levels. LDLs contain more cholesterol than any of the lipoproteins and have an attraction for arterial walls. So elevated LDL levels correlate most closely with an increased incidence of atherosclerosis and CAD. Therefore, low serum LDL levels are desirable. Guidelines for treating elevated LDL cholesterol are based on a person's 10-year risk for having a non-fatal MI or dying from a coronary event and his or her LDL levels. The following information generates a risk score. So we're going to look at age, gender, use of tobacco, systolic BP, use of BP drugs, total cholesterol, and HDL levels. A 10-year risk calculator is available on the NIH website. If you're not familiar with that, you should take a look at it. In general, individuals with no or only one risk factor are considered at low risk for the development of CAD. And the LDL goal is less than 160. Those at very high risk of CAD and multiple risk factors. The LDL goal for this group is to be under 70. So let's continue on and talk about hypertension. Hypertension is the second major risk factor in CAD, which is defined as a blood pressure of 140/90 or 130/80 if the patient has diabetes or chronic kidney disease. Hypertension increases the risk of death from CAD tenfold in all persons. The stress of an elevated BP increases the rate of atherosclerotic development. This relates to the shearing stress that causes endothelial injury. Traumatic lifestyle changes should begin in people with pre-hypertension, so that includes people with blood pressures of 120 to 139 over 80 to 89. Those with stage 1 or stage 2 hypertension often required more than one drug to reach therapeutic goals. Tobacco use. A third major risk factor for CAD is tobacco use. The risk of developing CAD is 2 to 6 times higher in those who smoke tobacco or use smokeless tobacco than in those who do not. Further, tobacco smoking decreases estrogen levels, placing premenopausal women at a greater risk for CAD. Risk is proportional to the number of cigarettes smoked. Changing to lower nicotine or filtered cigarettes does not affect risk. Nicotine in tobacco smoke causes an epinephrine and norepinephrine release. The neurohormones cause an increased heart rate, peripheral vasoconstriction, and increased BP. These changes increase the cardiac workload. Tobacco smoke is also related to an increase in LDL level, a decrease in HDL level, and a release of toxic oxygen radicals. All of these add to vessel inflammation and thrombosis. Carbon monoxide, a byproduct of combustion found in tobacco smoke, affects the oxygen carrying capacity of hemoglobin by reducing the sites available for oxygen transport. Thus, the effects of the increased cardiac workload, combined with oxygen depleting effect of carbon monoxide, significantly decrease the oxygen available to the myocardium. There is also some indication that carbon monoxide is a chemical irritant and causes injury to the endothelium. The benefits of smoking cessation are dramatic and almost immediate. CAD mortality rates drop to those of non-smokers within 12 months. However, nicotine is highly addictive and often calls for intensive intervention to assist people to quit. Chronic exposure to environmental tobacco, so secondhand smoke, also increases the risk of CAD. People who live in the same household as the patient should be encouraged to stop smoking. This reinforces the individual's effort and decreases the risk of ongoing exposure to environmental smoke. Pipe and cigar smokers who often do not inhale have an increased risk of CAD similar to those exposed to environmental tobacco smoke. So physical inactivity is the fourth major modifiable risk factor. Physical inactivity implies a lack of adequate physical exercise on a regular basis. An example of health-promoting regular physical activity is brisk walking, so 3 to 4 miles per hour for at least 30 minutes, 5 or more times a week. Physically active people have an increased HDL level. Exercise improves thrombolytic activity, thus reducing the risk of clot formation. Exercise may also encourage the development of collateral circulation in the heart. Then you have obesity. The mortality rate of CAD is statistically higher in those of obese persons. Obesity is defined as a body mass index of greater than 30 and a waist circumference of greater than 40 inches for men and 35 inches for women. The increased risk for CAD is proportional to the degree of obesity. There is also evidence that people who tend to store fat in the abdomen, so an quote-unquote apple-like figure, rather than in the hips and buttocks, so the pear-type figure, have a higher incidence of CAD. As obesity increases, the heart grows and uses more oxygen. In addition, there is an increase in insulin resistance in obese individuals. Diabetes. The incidence of CAD is 2 to 4 times greater among persons who have diabetes, even those with well-controlled blood glucose levels, than the general population. The patient with diabetes manifests CAD not only more frequently, but also at an earlier age. The person with diabetes has an increased tendency toward endothelial dysfunction. This may account for the development of fatty streaks seen in these patients. Diabetic patients also have alterations in lipid metabolism and tend to have a high cholesterol and triglyceride level. Management of diabetes should include lifestyle changes and drug therapy to achieve a hemoglobin A1C of less than 7. And then finally, metabolic syndrome refers to a cluster of risk factors for CAD whose underlying pathophysiology may be related to insulin resistance. These risk factors include obesity, as defined by increased waist circumference, hypertension, abnormal serum lipids, and an elevated fasting blood glucose. So, the appropriate management of risk factors in CAD may prevent, modify, or slow the progression of the disease. In the United States, during the past 26 years, there has been a gradual and persistent decline in cardiovascular-related deaths. The decline relates to the efforts of people to become generally healthier, as well as advances in pharmacologically and technology to treat CAD. Prevention and early treatment of heart disease must involve a multifaceted approach and needs to be ongoing throughout the lifespan. Identification of high-risk persons. So clinical manifestations of CAD will not be apparent in the early stages of the disease. Therefore, it's extremely important to identify people at risk for CAD. So risk screening involves obtaining a thorough health history, question the patient about family history of heart disease in parents and siblings, note the presence of any cardiovascular symptoms, assess environmental factors such as eating habits, type of diet, level of exercise, and illicit lifestyle patterns. Include a psychosocial history to determine tobacco use, alcohol ingestion, recent stressful events, so for an example like a loss of a spouse, and the presence of any negative psychologic states. Some examples include anxiety, depression, or anger. The place of work and the type of work provides important information on the kind of activity performed, exposure to pollutants or noxious chemicals, and the degree of stress associated with work. Identify the patient's attitudes and beliefs about health and illness. This information can give some indication of how disease and lifestyle changes may affect the patient and can reveal possible misconceptions about heart disease. This slide gives a nice clear picture of saturated, monosaturated, and polysaturated fats and some examples of each. CAD is a progressive disease, and patients may be asymptomatic for many years, or they may develop chronic stable chest pain. When the demand for myocardial oxygen exceeds the ability of the coronary arteries to supply the heart with oxygen, myocardial ischemia occurs. Angina, which is just another word for chest pain, is the clinical manifestation of reversible myocardial ischemia. Either an increased demand for oxygen or decreased supply of oxygen can lead to myocardial ischemia. The primary reason for insufficient blood flow is narrowing of coronary arteries by atherosclerosis. For ischemia, secondary to atherosclerosis, to occur, the artery is usually blocked or stenosed 75% or more. On the cellular level, the myocardium becomes hypoxic within the first 10 seconds of coronary occlusion. In ischemic conditions, cardiac cells are viable for approximately 20 minutes. With restoration of blood flow, aerobic metabolism resumes, contractility is restored, and cellular repair begins. Myocardial cells are deprived of oxygen and glucose needed for aerobic metabolism and contractility. Anaerobic metabolism begins and lactic acid accumulates. Lactic acid then irritates the myocardial nerve fibers and transmits a pain message to the cardiac nerves and upper thoracic posterior nerve roots. This amounts for referred cardiac pain to the shoulders, neck, lower jaw, and arms. And on this slide, it's going to just give you the examples of where the pain usually radiates to and from. So, placement of a coronary artery stent. A stent is an expandable mesh-like structure designed to keep the vessel open by compressing the arterial wall. Because stents are thrombogenic, anticoagulants are used during PCI to help prevent the abrupt closure of the stents. So we're going to use heparin, aggrastat, something like that. After PCI, the patient is treated with dual antiplatelet agents, something like Brilinta and aspirin, until the intimal lining can grow over the stent and provide a nice and smooth vascular surface. Many stents are drug-eluted stents. This type of stent is coated with a drug that prevents the overgrowth of new intima. The primary cause of the stent restenosis. Patients with this type of stent may be on antiplatelet drugs for 12 months or longer. The most serious complication from a stent placement are abrupt closure and vascular injury. So in this slide, you can see very clearly the before the PCI placement and after the PCI placement. When ischemia is prolonged and not immediately reversed, acute coronary syndrome develops and encompasses the spectrum of unstable angina. Which can lead to an NSTEMI or a STEMI. And you can see that in the diagram above. Although each remains a distinct diagnosis, the ACS reflects the relationship amongst these disorders. ACS is associated with the deterioration of a once stable plaque. The once stable plaque ruptures, exposing the intima to blood and stimulating platelet aggregation and local vasoconstriction with thrombus formulation. This unstable lesion may be particularly occluded by a thrombus, manifesting as a UA or a non-STEMI, or totally occluded by a thrombus, which then manifests into an actual STEMI. What causes a coronary plaque to suddenly become unstable is not well understood, but systemic inflammation is thought to play a role. Patients with suspected ACS require immediate hospitalization. MIs are usually described based on the location of the damage, so either anterior, inferior, lateral, septal, or posterior wall infarction. Most involve some portion of the left ventricle. The location of the infarction correlates with the involved coronary circulation. For example, the right coronary artery provides blood supply to the inferior wall. Blockage of the right coronary artery will result in an inferior wall, MI. Anterior wall infarctions result from blockages in the left anterior descending artery, as shown in this figure. Blockages in the left circumflex artery usually cause lateral and or posterior wall MIs. Damage can occur in more than one location, especially if more than one coronary artery is involved. The degree of pre-existing collateral circulation also influences the severity of the infarction. An individual with long history of CAD will develop collateral circulation to provide the area surrounding the infarction site with a blood supply. This is one reason why a younger person may have a more serious first MI than an older person with the same degree of blockage. Acute myocardial infarction in the posterolateral wall of the left ventricle. This is demonstrated by the absence of staining in the areas of necrosis. So you can see that by the white arrow. Note the scarring from a previous anterior wall myocardial infarction, if you could see from the black arrow. So in response to the release of the hormones, your blood pressure and your heart rate may initially increase. The BP may later drop because of decreased cardiac output. If severe enough, this may result in decreased renal perfusion and urine output. Crackles, if they're present, may persist for several hours to several days, suggesting left ventricle dysfunction. Jugular venous distension, hepatic engorgement, and peripheral edema may indicate right ventricular dysfunction. Cardiac examination may reveal abnormal heart sounds that may seem distant. Other abnormal sounds suggesting ventricular dysfunction are S3 and S4. In addition, a loud holosystolic murmur may develop and may indicate a septal defect. papillary muscle rupture, or valve dysfunction. The patient may experience nausea and vomiting. These symptoms can result from reflex stimulation of vomiting center by the severe pain. They can also result from vasovagal reflex initiated from the area of the infarcted myocardium. The temperature may increase within the first 24 hours up to 100.4, or that's Fahrenheit, or 38 degrees Celsius. The temperature elevation may last for as long as a week. This increase in temperature is due to a systemic inflammatory process caused by myocardial cell death.